On to our highlights of the RTN programme, and we welcome Nick Gulliver, who's from the Greater Glasgow and Clyde Trust.
Very much. I know we're running over a little bit, so I'm going to speed up things a wee bit. I don't want to get between everyone and the comfort break. Anyone's crossing their legs right now. Thank you, Danny and John. Excellent warm-up, men. Unlike John, I am sackable, so I'll be careful what I say. I'm not anywhere near my degenerative brain era either. I am nearer to my degenerative knee era, though, so for those who are doing the fun run tomorrow, I will be joining, but I'll probably be near the back of the pack. It's an honour to be invited here today. I'm aware that for many centres it's quite difficult for radiographers, technologists and nurses to attend a three-day meeting, so we all give thanks to those of our colleagues who are still back at our bases, keeping departments ticking over. For many RTNs, it might be your first BNMS meeting. It might be your first for a while. Anyway, let's just dive in, shall we? There are two sessions tomorrow dedicated to RTN abstracts, profit papers. Please don't limit yourselves to these, though, if you are a radiographer, technologist or nurse. You can go to other sessions that have papers that may be relevant to RTNs. A couple of these, for instance. This is in the Young Investigators Prize session. This paper from the Christie Group, the authors hypothesized that the incidence of delayed imaging in melanoma sentinel node scans could be predicted using a statistical model. This could be useful when considering surgical scheduling or gamma camera utilization. This centre had a significant proportion of their workload was sentinel node scans, and many of them required delayed views. Independent variables of sex, primary location, and age were used, and injected activity, retrospectively analysed for 5 years' worth of patients. The authors found that the incidence of delayed imaging coincided with age and primary site, and therefore delayed imaging, the prediction of delayed imaging being needed, could be made on data that was included in the referral alone. The authors concluded that this might be useful in improving efficient gamma time scheduling and surgical scheduling. As Danny mentioned earlier, we're all getting used to the use of AI in our everyday lives. This ChatGPT is a large language model, as we all know. This group from the Royal Free used ChatGPT to improve the readability of their patient information leaflets. The authors highlighted that as up to a quarter of adults have poor literacy skills, having patient information leaflets that are understandable is critical. They used 2 patient information leaflets, one for I131 thyroid cancer treatment, one for thyrotoxicosis, and they split them into 300-word sections. ChatGPT was then asked to improve the readability of each section using 3 different prompts. The improvements in readability were then assessed both qualitatively and quantitatively. The reviewers found that ChatGPT-generated versions retained the meaning of the original, but require editing before inclusion in a patient information leaflet. The authors concluded that ChatGPT can successfully redraft information leaflets to improve readability, but careful prompt engineering and proofreading was necessary. Moving back to the dedicated RTN profit paper session, this is a paper from the Royal Marsden Group. The INSPIRE clinical trial is aiming to recruit 150 patients to investigate the potential of dosimetry for radioiodine treatment planning of thyroid cancers. Setting up protocols and imaging schedules for such studies includes several important considerations to achieve adequate patient recruitment and high-quality data. The author's aim was to assess UK readiness for multi-centre interventional clinical trials incorporating radiation dosimetry, and the author sent questionnaires to participating sites during their trial setup. Recruitment, data collection and data analysis can be challenging in these observational trials. And authors state that a high proportion of patients decided or declined from participation after initially showing some interest. The concerns about radiation exposure and anxiety were commonly ascribed to the underlying cause for dropout. The authors showed that readiness to perform in-house dosimetry is currently very limited. The results from the survey show that from the 10 participating sites, just 3 had cameras calibrated to perform on quantitation, and no centres currently performed I-131 dosimetry. The authors conclude that deeper understanding of the factors limiting performing dosimetry, whether that be staffing levels or camera time or other considerations, would be useful for planning further trials. And continuing with therapies, PRRT, of course, is an established treatment in NETs, as we all know, and has been shown to extend survival. However, quality of life data post-PRRT is still somewhat limited. This paper from the Royal Free Group revisits initial data originally from 2017. Around 300 patients were treated with 4 cycles of lutetheria and completed quality of life questionnaires before the first session of administration as a baseline, and quality of life questionnaires following each of the 3 succeeding treatments were available for analysis. The authors concluded that this revisited study demonstrates consistency in improving the patient's quality of life, reduction of GI and endocrine symptoms, improved emotional and social function, and reduced disease-related worries, with improvement seen as quickly as the first cycle of treatment. And continuing the theme of neuroendocrine therapies, this is a paper from the Oxford group. Their aim was to develop an alternative administration for I-131 MIBG therapies following the withdrawal of GE MIBG administration sets. And this is an example of kind of some of the areas that the RTN program often excels in, whether that be practical on the shop floor solutions to problems we might find in our day-to-day practice. The group, they modified their method of lutetheria administration to allow for the simultaneous administration of 3 vials of I-131 MIBG via a daisy chain system. This was utilizing existing pumps, and they were able to purchase through normal NHS supply chain. It was trialled using saline and technetium and verified with I-123 MIBG. And dose rate monitors were used to monitor the flow of activity through the system and to verify the dilution that was achieved prior to administration. The measurement of vial residues confirmed that appropriate treatment was delivered. And the authors conclude that this setup was a more consistent concentration of activity delivered throughout the course of the administration, and it's an effective alternative delivery system to the withdrawn GE system. Moving on to the subject of advanced clinical practice, this is another area that's frequently focused on within the RTN program, professional practice. This is a paper from the Maidstone group. They provide a brief background look at underlying principles of advanced clinical practice for radiographers, technologists, and nurses working in nuclear medicine. They look at the available Health Education England accreditation pathways for allied health professionals, and they consider why national accreditation was pursued in their centre in particular. The authors outline the pillars of advanced clinical practice and highlight that many of those working already within nuclear medicine may not realise that they're already meeting the 4 ACP pillars. The authors present their own personal journeys of 2 nuclear medicine radiographers and a technologist who pursued national accreditation as ACPs working in nuclear cardiology and in therapies. And the authors describe the two routes for Health Education England's accreditation, through a completion of an accredited master's degree, and the other one through HE's equivalence e-portfolio route. And the authors conclude that there is no reason why nuclear medicine expert practice by RTNs should not meet the criteria to become nationally accredited advanced clinical practitioners. Relating to enhancing practice or role extensions, this is a paper from the Newcastle group. They identified the training needs for clinical technologists to perform contrast-enhanced SPECT-CT. This was in order to improve patient treatment planning, pathway and outcome for patients undergoing surgery for primary hyperparathyroidism. The service was initially obviously started to increase the sensitivity and accuracy of identifying parathyroid adenomas. Prior to implementing the service, they already performed SPECT-CT and had a success rate of about 61%. It'd be interesting to hear what their accuracy rate is after introducing contrast. Here you can see some example images. Few SPECT-CT images showing the sesame avid nodule. CT without contrast in the middle, where the nodule is a bit difficult to identify. The contrast-enhanced CT shows nice enhancement in the avid nodule. The authors go on to show that technologist training needs were identified. Existing skills and knowledge was adapted to broaden the scope of their role to allow diagnostic CT imaging to be performed using iodine. It's now an established service, and authors have some interesting cases and accounts of their own practical experiences. And the centres now perform several hundred, with very few adverse incidents. Related to the setting up of contrast, enhanced hybrid imaging, specifically for PET-CT. This is in the education sessions for RTNs using contrast tomorrow morning. Full disclosure, this is from my own centre. And the author takes us through a process of service planning and implementation of a one-stop shop service, including designs of scanning protocols. The protocol design here is presented. This includes for lymphoma, but other ones are also included in the talk on lung cancers and head and neck cancers. In this morning's joint session with the SOR on non-medical reporting, we have Sue Johnson from the SOR, who will take us on a journey through the long and somewhat fractious history of non-medical reporting. In the early 20th century, non-medical reporting of X-rays was very commonplace, but then fell to the wayside. Plain film reporting and ultrasound reporting really took off again in the 1990s. Non-medical reporting was not welcomed by all, and today still remains some opposition. The authors go on to describe how the College of Radiographers has a framework for education. Advanced and consultant practice radiographers, including those with medical imaging investigation roles, are essential to the future of medical imaging services. In my mind, all departments should be considering going down this avenue. Other sessions include this afternoon's joint physics and RTN session on competitors, carers and risk communication. And on Wednesday, there's a session touching on some management topics. In addition to learning, there's also an RTN social event this evening, not to be missed. Might be a few hangovers tomorrow morning. Above all, my recommendation as a seasoned attendee at BNMS is to relish the opportunity to network, to meet others in your field, to find out how other departments do things that you might be doing, and take them back to your own centres. And I think that's about it from me. I'm going to hand over to Stuart, I think, for the posters.